So many times you see this type of fixation, which is called as mesofracture fixation, where the posteromedial condyle is totally off and it's not fixed. 7 months old patient cannot bear weight, and you are not supposed to do this type of plate fixation where the complete posteromedial fragment is not fixed. So then I went down, did this through fracture osteotomy, elevation and posteromedial plating, and completely united. So most of the problems are in coronal plane fractures. So we have already discussed the posterolateral. So there is another one which is a posteromedial. And why it is so? Because they are difficult to reduce and achieve fixation by conventional methods. Timing of surgery, soft tissues, modalities, they vary as per the type, and there are certain complications. So proximal tibia needs CT scan. In around 20% cases after CT scan your plan changes. So it is statistically proved. So timing of surgery depends on the soft tissue, 1 stage versus 2 stages, and failure to identify need for 2 stage is certainly inviting the complications. So proximal tibia fracture should be considered as substantial soft tissue injuries with a bony element. So upper end tibia is nothing but the soft tissue management, and then secondarily you have to manage the bone. So if this is your skin condition, how will you go for surgery? So you have to first take care of soft tissues, spanning X-fix followed by internal fixation. As everybody showed, Dr. Milind also showed that now the Leo classification is more important, and now it's Schatzger's Leo, both combined together is more important. So this is the further modification of Leo classification. So this is the plan which is proposed, that once you see the fracture or 3-column concept, the CT scan, 3-dimensional reconstruction, then you have to first identify the key articular surface. So if this is the key articular surface, then approach is articular surface specific. If there is a soft tissue injury, everything differs. And injury mechanism, compression versus tension, then plates according to that, and approaches for the plating. So this is the comprehensive plan. We can do posteromedial plating, we can do posterolateral plating, we can do PM plus PL, and combination of all these upper end tibia. So coming to a few examples, upper end tibia, posteromedial fracture, classical, needs posteromedial buttress plate. You can have this a good posteromedial buttress plate. There was some lateral fracture which was fixed with screw. Another posteromedial fracture, classical CT scan showing posteromedial fracture, which can be done in prone, supine with angle frame, or supine with figure of 4. I do it with supine with angle frame. It is very easy. You stand on the opposite side. And then incision, take care of pes anserinus. If needed, you ligate and then resuture it again. Osteotomy in fracture, reduction in extension, that is very important, where the angle frame helps, because figure of 4 doesn't give you reduction. Then reduction in extension, fixation by AP screw, then buttress plate, and closure of pes anserinus, and even with the buttress plate, simple recon plate, you will get a good end result. Another case of posteromedial fracture, same fracture, fixed with posteromedial plate, 1 year follow-up, full function. So buttressing the deforming force is very important to get your good function. So sometimes the posteromedial is another added by medial fracture. So medial fracture with posteromedial fracture, they are two different. So they will not be buttressed by single plate. So you need 2 plates. So medial condyle is fixed with lateral to medial screw, medial to lateral screw, 1 anteromedial plate, 1 posteromedial plate. So that will take care of your complete medial complex fractures. So this is also one scenario you have to be aware of. For this, you have to be very careful about your soft tissue selection. Wait till you see a wrinkle sign. Another ghastly case where you can see a fracture displaced completely with subluxated knee. If you see this CT scan, the entire articular surface is out from the, this is the articular surface which is out, and this is the CT scan which is completely. After opening lateral incision, you can see a medial condyle which is coming out from the lateral side with the ACL. So I had to use 2 incisions, a lateral to medial screw, ACL screw, and a medial plate, classical medial plate, posteromedial plate. And this is 1 month follow-up. This is full function at the end of 6 months. even with this such ghastly injury. Posterolateral corner I will just touch upon because he has properly explained. This was the tibial lateral condyle fracture. Plan is to fix it with posteriorly, no, but I use, as he said, extended lateral incision. Submeniscal window is my favorite approach. So if you see that this is the posterior fragment, I use the dura retractor, which is more curved. So after reduction, I use that dura retractor as a spacer or spoon behind the posterolateral condyle and reconstruct on that, put anteroposterior screw, wires, and then take a variable angle incision. So similarly, if you see, this is a arthrotomy done. Articular depression is around 1 centimeter here. This is a lateral fragment purchased with the K-wire, and then it is elevated. Now you can see there is no step in between the posterolateral fragment and the anterolateral fragment. I have used the small dura behind this and to get a proper reduction. And this is the post-op imaging. And this is a union. Another bicondylar coronal. Look at this, a posteromedial posterolateral. What a ghastly injury it is. If you see the lateral, it is, the knee is completely going behind. And this is the injury. Here you can see entire thing is void. So here my most favorite approach is extended posteromedial. So prone, use a spike, elevate everything on the opposite side. You can see that these spikes are on the lateral side. This is the medial side, this is the lateral side. This is one plate, this is second plate. So you can put this T plate, recon plate for the posteromedial, the zero column screw, and this is the perfectly elevated posterolateral posteromedial fracture. Another case in complexity of this fracture is because you have to you don't underestimate the power of DVT. Many of these upper end tibia fractures are associated with DVTs, which I screen each and every patient preoperatively before a DVT screening. The DVT was a prophylactic, a therapeutic dose was given for 3 days and then fixed with twin plating and then good result. Special situation, if you see this fracture, see this, where is the condyle? This condyle is completely behind, and this patient had a young patient who had a vascular insult. So we had to take him to the OT immediately, prone position. And if you see, first we did fasciotomy, whether it is live or alive, not. So then after fasciotomy, confirmed that this is a viable limb, then we went in, and this was completely between the vein and an artery, that fragment has come up. So it was very difficult to dissect it out and relocate that fragment back, and did the posterior plating. So this is the posterior plating, posterolateral, dead posterior plating, additional medial to lateral screws, and an external fixator. This patient is still under treatment. It is around 6 weeks now. Another patient, same type of injury, posterolateral, posteromedial, and then there was a vascular insult, vein graft, spanning external fixator, vascular repair, fixation, fasciotomy, and this patient was treated with secondary closure of the fasciotomy. He continued with the fixator, then cast, and then he had functionally a good result, not excellent, but then he was doing all the activities. You can see these type of patients which come to you, blisters with the lower tibial pin traction used, and this is the X-ray, and if you see the lower tibial pin traction, that person has caused the fracture here of the distal tibia as well. And then external fixator was used, percutaneous screw for the upper end tibia. Blister started healing, and blister healed, and then did the posteromedial, anterolateral plating, and this patient had a good full function recovery after the second stage surgery. So friends, there are effort guidelines for upper end tibia. 3-column concept has to be used. Soft tissues are very, very important. First stage or 2 stage, you have to take care of soft tissues. Upper end tibia is not a bony surgery, it is a soft tissue surgery. Open reduction of articular surface and MIPO for diaphysis is important, and fragment specific approach is very, very important, and our goal should be articular restoration, limb alignment, and early mobilization. So you should mobilize your patient ASAP to get range of motion back. So identify fracture morphology, proper imaging, know the deforming force, proper timing of surgery, buttress accordingly, and stabilize and mobilize. Thank you.